Hello and welcome to my channel where we talk all things rheumatology related. Today we're going to talk about a very common and important symptom seen in clinical practice, which is lower back pain. Why is this such an important topic? Well, low back pain is the leading cause of disability worldwide, often affecting young adults. In fact, 60 to 80% of people will experience at least one episode of low back pain in their lifetime, and most of them will have recurrent episodes. The differential diagnosis can be broad and sometimes challenging, making it essential to understand the nuances. We can classify low back pain based on its duration as acute, which is less than 4 weeks, subacute, which lasts 4 to 12 weeks, and chronic, which lasts more than 12 weeks. Most cases of low back pain are acute and benign, often improving within a few weeks with pain relief and physical therapy. For example, low back pain that starts acutely after going to the gym or after maintaining a bad posture. As I mentioned earlier, low back pain can have many different causes, ranging from completely benign to more serious conditions. The most common causes are usually mechanical or degenerative, such as spondylosis, disc herniations with radiculopathy, muscle strains, and other wear and tear issues. The spine is made up of many structures that can be affected, such as bones, discs, muscles, ligaments, and joints. And in young people with acute back pain, it's often difficult to pinpoint the exact source, even with extensive imaging such as MRI. The good news is that in most of these cases, the pain improves with consistent physical therapy and proper pain management. In patients with a recent history of trauma, we always have to rule out fractures or other complications, as these require a different approach. Similarly, patients with osteoporosis or at high risk of osteoporosis who develop acute back pain should be evaluated for fragility fractures and treated appropriately. We should always keep in mind referred causes of back pain, for example, piriformis syndrome, where pain originates from the gluteal region but radiates to the lower back. Another crucial aspect to consider is infection. Spinal infections are rare but potentially serious. They should always be suspected in high-risk patients, such as those with diabetes, chronic corticosteroid use, immunosuppression, recent invasive procedures, IV drug use, indwelling catheters, recent sepsis or bacteremia, or pressure ulcers on the lower back. To investigate a possible infection, we usually perform blood tests like complete blood count, inflammatory markers, and blood cultures, and also imaging studies, typically a contrast MRI or a contrast CT scan if MRI is not available. Two more important categories of back pain that we'll discuss shortly are malignancies and inflammatory causes. But first of all, we should not forget that low back pain can also come from visceral or referred sources, such as aortic aneurysms or dissections, gastrointestinal issues like acute pancreatitis or cholecystitis, renal causes such as colic or pyelonephritis, and gynecological conditions including endometriosis, ovarian cysts, or torsion. Even fibromyalgia and herpes zoster can present with low back pain. When evaluating a patient with low back pain, it is essential to look for red flags, which are warning signs that might point to a serious underlying condition requiring urgent attention. Some red flags are linked to acute or severe problems, such as fever, which could suggest an infection, recent trauma raising concerns for fractures, or neurological symptoms like saddle anesthesia, bowel or bladder dysfunction, or progressive muscle weakness, which may indicate nerve compression or cauda equina syndrome. Other red flags hint at more serious chronic or systemic causes, including unexplained weight loss or other systemic symptoms, a history of cancer, night pain or progressive pain that does not improve with rest, which can suggest malignancy, or chronic morning pain and stiffness, often associated with inflammatory conditions such as ankylosing spondylitis. Identifying these warning signs early is crucial, as they guide us towards the right investigations and ensure that potentially serious causes aren't missed. Now let's talk a bit more about those red flags. First of all, unintentional weight loss. What exactly does that mean? Unintentional weight loss refers to losing weight without actively trying, meaning you haven't changed your diet, started exercising more, or made any lifestyle adjustments that would explain it. This kind of weight loss can be a sign of several underlying conditions, including malignancy, chronic infections such as tuberculosis, endocrine disorders like even psychiatric causes such as depression. Clinically, it's defined as losing 2 to 3 kilograms per month, or losing more than 5% of your body weight over 6 to 12 months, or a total loss of around 4 to 5 kilograms over the same time period without any intentional effort. So, when a patient reports this kind of unexplained weight loss, it's an important red flag that deserves further investigation. Next up is cauda-equina syndrome, which occurs when the bundle of nerves at the lower end of the spinal cord, known as the cauda equina, becomes compressed by various causes such as large disc herniations, tumor, trauma, or severe spinal stenosis. This nerve compression leads to a characteristic symptom called saddle anesthesia, which means loss of or alteration of sensation in the areas that would come in contact with the saddle, the inner thighs, buttocks, and perineal region. It is also commonly associated with urinary retention, bowel dysfunction, and lower limb weakness. Cauda-equina syndrome is a medical emergency that requires urgent evaluation and surgical decompression to prevent neurological damage. One of the malignant causes of low back pain is multiple myeloma. Multiple myeloma is a malignant proliferation of plasma cells in the blood marrow. These abnormal plasma cells produce a monoclonal immunoglobulin, often called M protein, that can cause a variety of systemic effects. In clinical practice, we often remember the key manifestation of multiple myeloma with the mnemonic CRAB. C comes from calcium elevations, R from renal impairment, A from anemia, and B from bone lesions. These bone lesions cause the low back pain. Multiple myeloma causes lytic bone lesions, particularly in the spine, ribs, and skull, which can present as persistent, deep, and often nocturnal pain. These lesions weaken the bone structure and increase the risk of pathological fractures or vertebral collapse, both common sources of back pain in these patients. If multiple myeloma is suspected, key investigations include serum protein electrophoresis, urine protein electrophoresis, serum free light chain assay, bone marrow biopsy, and skeletal imaging, typically whole-bodied low-dose CT or MRI. Furthermore, it is also important to remember that the spine is a common site for metastatic cancer. Tumors from other organs can spread to the vertebrae and cause back pain, sometimes even before the primary cancer is diagnosed. The cancers that most frequently metastasize to the spine include lung cancer, gastrointestinal cancer, breast cancer, renal or prostate cancer, and lymphoma. So, when a potential metastatic lesion is found in the spine, these organs are typically the first places to screen to find the primary tumor. Now let's move on to inflammatory causes of low back pain. If you see a young adult, often male, with low back pain lasting more than 3 months, there are certain features that should raise suspicion for axial spondyloarthritis. Typical characteristics include pain that is worse in the morning or after long periods of rest, pain that improves with activity or NSAIDs, pain that may wake the patient in the second half of the night, and sometimes associated alternating buttock pain. These patients may also have other manifestations, such as uveitis, dactylitis or sausage digits, peripheral arthritis, psoriasis, or gastrointestinal symptoms. A family history of ankylosing spondylitis is also another important clue. On investigation, many of these patients are HLA-B27 positive, may show elevated inflammatory markers, and can have characteristic changes on MRI or X-ray of the sacroiliac joints. Unfortunately, even with modern diagnostic tools, there is often a long delay before these patients are diagnosed, which can lead to complications like chronic stiffness and reduced mobility. Early recognition is key to preventing long-term disability in these patients. When evaluating a patient with low back pain and red flags, certain laboratory tests can provide important clues about the underlying cause. ESR and CRP help to assess the inflammation, which can point to infection or inflammatory back pain. Complete blood count can reveal anemia or other blood abnormalities, such as leukocytosis in infections. Serum calcium and proteins can be especially useful when suspecting multiple myeloma, following the CRAB mnemonic. Alkaline phosphatase may be elevated in bone lesions. And blood cultures can be especially useful when evaluating a possible spinal or systemic infection. Not every type of low back pain signals something serious or urgent. In fact, there are several features that usually point to a benign mechanical cause. I like to think of these as beige signs, not alarming, just everyday back pain. These include pain that starts after physical strain or activity, and that worsens with movement but improves with rest. Pain that typically gets better within 4 to 6 weeks. No night pain or constitutional symptoms like fever, weight loss, or fatigue. No morning stiffness, no systemic illnesses or risk factors, and the normal blood work. Patients with these features usually have mechanical or benign acute back pain, which often resolves with rest, analgesics, and physical therapy. Guidelines generally do not recommend imaging for patients with these benign mechanical low back pain features because, in most cases, nothing abnormal is found and imaging doesn't change treatment or prognosis. Imaging is usually reserved for situations when pain persists despite appropriate treatment or neurologic symptoms appear, such as paresthesias, numbness, or motor weakness. This approach helps avoid unnecessary tests while ensuring that serious causes aren't missed. When it comes to treating benign mechanical low back pain, the mainstay are physical therapy, pain relief, and continued physical activity. Guidelines specifically recommend against prolonged bed rest because it may actually worsen the outcomes and is associated with longer and recurrent episodes of pain. The key point is that physical therapy should go beyond episodic treatment. Patients should be encouraged to perform daily exercises, learn how to use the spine correctly during daily activities, and if going to the gym, perform supervised exercises under expert guidance. Surgery or further imaging is only considered if pain persists despite appropriate treatment or neurological symptoms appear. For the specific causes we discussed earlier in the video, such as infection or malignancy, treatment is tailored accordingly. For infections, we use prolonged antibiotics. For axial spondyloarthritis, we use NSAIDs or newer treatments such as biologics. For malignancies, we use cancer-specific therapies, and for fractures or other surgically manageable cases, we use surgical interventions. This approach ensures patients get targeted care, avoid unnecessary interventions, and maximize their long-term function and quality of life.